So sorry about that. I had a glitch in my computer. So let me go ahead and just get back to where we were. Okay, so sorry about that. So I will be posting 2 short videos. The first one I think is 27 minutes, and this one should just be about 20. One quick thing I just realized, and I was so confused. I'm like, where's hypothyroidism? I skipped that. So let me just finish the parathyroid real quick because it's super, super simple. So basically, hypo means too little thyroid, or hypo. So sorry. Hypoparathyroidism is too little, and we know that that has to do with absorption of calcium, and then hyper has to do with too much calcium in the blood. So that's pretty much, I mean, really what it's about. So if you have hyperparathyroidism, you're going to have too much of this hormone going into the blood, causing an increased serum level of calcium. So that's how that would be an indication potentially that that's going on. And this has to do with basically calcium moving outside of the bone and going into the blood. And then for the other one, it's going to be the opposite. I don't know why that this one's so much easier for me to explain first. And now the other one, it's going to be the opposite, where you're holding onto it so you don't have enough in the this means that calcium stays in the bones instead of being moved into the blood. And remember, we need calcium. We need it to be even. Again, homeostasis. We need it to be even in order for our, because calcium in the blood helps with muscle movement and twitching and things like that. Calcium is very important and does have to do with tetany, which was on your quiz as well. Okay, now I just want to go back. So sorry. We actually were supposed to start on page 795. I was like, where's hypothyroidism? So, which in my personal opinion is one of the easiest ones, just because it's done with medications, kind of clear cut. So we have some, just a little background. Of course, hypo means under, so we don't have our thyroid working to optimal level. And if this does happen, just like with hyperthyroidism, and I'm not going to re-explain the primary and secondary, it's all the same. So it's just, it's the exact same thing. It can happening from the thyroid gland or from the hypothalamus or the pituitary. Depends on who's telling what to do and what's not working. But as far as how the signs and symptoms, they're going to be different, because remember, the thyroid has to do with metabolic rate. So this is considered to be hypo, so things are slowing down. So this is how I remember. Hypo is slower, it's lower, so things are going to start going down. So what that would mean is, instead of weight loss, unfortunately that would be weight gain. And hypo, I think of hypo, that's tired, I'm feeling super fatigued. And if you're not moving a lot, what can happen? Constipation, which is also, so all of these kind of connect. I don't know, maybe that's why I like the thyroid, because it's just, it makes sense to me personally, and I can just connect it. Instead of feeling hot, you're going to feel cold. And then, what else here? Just bradycardia, shortness of breath, dry skin, and dry hair. And those are probably the two that don't make quite as much sense to me. You just have to memorize those. So this would be, if someone came in and was explaining this, you might think, again, it may not be this. Something else may be going on. It could be hormonal, like menopause. It could be many things. But many people, in my experience, this is totally my experience, is that they start to notice, like, why am I gaining weight? I'm not doing anything different. I'm 27. I'm exercising, I'm doing this, I'm doing that. Like, what, like all of a sudden I'm just gaining weight. There's no change. Like, I didn't start birth control. I'm not saying that causes a ton. It's not supposed to. So this usually will get them to go and to see the physician, not just the weight loss or the weight gain, but just in general. And, as we had mentioned in, I think, lecture one of the most common things we're going to do, of course, is take some blood. We're going to check and see, the levels of T3, T4, and, are they low? Are they high? What's going on? We're going to check TSH. And depending on what the cause is, that's going to tell us, based off of those things, what's actually causing the problem. Is it the pituitary gland? Is it the thyroid gland? What is actually happening? And hypothyroidism normally is just treated with thyroid replacement therapy, basically. And that's when I was talking about Synthroid and levothyroxine. And I may have accidentally said that. Sorry about that if I did. It's not an excuse. I had a full double clinical day today and I'm not feeling well. So I apologize if I said that earlier. It would make sense. Obviously, if you have hypo, that's when you're going to replace it. If I did say it on the hyper, I apologize. That's when you remove stuff and get it out, rather, because you have too much. So when you have too little, you want to add it in order to basically, again, create homeostasis. And that's when you're going to start feeling better because you're getting what you need. So now what I want to do is talk about the adrenal glands, because that's the one thing that we, in my opinion, something as nurses, it's a very important topic. And our adrenal glands do many, many things, as we know. And we know that we have two different parts of them. We know that they set up the kidneys. We know a lot of the pathophysiology. So let's talk a little bit more about the nursing part of it. So basically, we're going to start with, disorders, because that's what this chapter or this part is about. And this is the last part that I have tabbed that we didn't go over. So just a reminder, we do have the adrenal medulla, and then we as well have the adrenal cortex, the cortex and medulla. Yes. Okay. So you'll read about there's some different types of tumors that can happen. One specifically on the medulla called, I have a little trouble saying it. They say it on Grey's Anatomy all the time. I can't say it, but it's on page 806 and it's in bold print. It's PHEOCROMOCYTOMA. My apologies. I'm just not a good speaker, if you will. And basically what this does is it's going to create more and more of your fight or flight. Remember, adrenal glands have to do with the fight or flight system and stress, and specifically the adrenal medulla. So if you have a tumor there and you're getting hypersecretion of your norepinephrine and epinephrine, this is obviously going to be pretty potentially noticeable. You could have different types of symptoms. If there's hyposecretion of epinephrine and norepinephrine, normally there aren't any symptoms. So that's kind of one way to tell the difference. Hypersecretion of cortisol from your adrenal cortex usually results in Cushing's syndrome. So this is where we come into Cushing's syndromes and Addison's. So if you have a hypersecretion, so too much cortisol from the adrenal cortex, this results in Cushing's syndrome. And this is how I remember it. Hyper is too much, and Cushing's syndrome, if you see a picture of it, think of like cushion. They're chubby. So that's how I put that together. And then Addison's disease, they're usually very thin. And it gives some more information about the tumor having to do with the adrenal medulla that I was not able to, unfortunately, actually verbalize. And they say it at the bottom here. I still can't do it. Sorry. It is what it is. I can't. But I want to get out the important stuff that I have highlighted here that I want you to really, what I think is important. Again, not memorizing every single thing. Okay, so Cushing's disease and Addison's disease. So let's go ahead and start with Addison's. So Addison's and Cushing's are two things that you're going to hear a lot of, and that's why I'm spending the time talking about that, because this is something that can come up on your NCLEX. This is something that you're going to be talked about, or depending on where you're working, or it's much more common. So when you have too little, remember loss of weight, gain of weight. So if you have too little adrenal gland insufficiency, that's Addison's disease. So several things are going to be seen by this. What we think is, and looking at your map, you can kind of see where it could potentially be happening. It could be a deficiency in certain sort of androgens. It could be primary, where it is just within itself being the adrenal gland in itself. It could be ACTH, different levels from the pituitary gland. It could be all sorts of different reasons why it's happening, but the point is that it is happening. So with Addison's disease, in particular, we think of it as an autoimmune disease. And as we had talked about in the quiz, I believe it was, that I think it was the quiz before, but it has to do with when your body's basically attacking itself. So that's what we think it is. We're not 100% sure. Not everything is always, we don't always know everything. Some signs and symptoms of Addison's disease, which of course I think is one of the most important things because you're going to be talking to your patient, is hypotension. And this has to do with the aldosterone. So remember, when you have aldosterone, this causes sodium and water retention. And this is, I think, the part that we really need to understand and make the connection. So you have aldosterone, and this is causing what? Sodium. What follows sodium? Water. So sodium and water retention in the kidney and potassium loss. So I'm actually going to read this specifically from the book. The most significant sign of Addison's disease is hypotension. Now think about this. Why? We want to know why. This is related to the lack of aldosterone. Remember that aldosterone causes sodium and water retention. Retention means it's not it doesn't let it go. In the kidneys, and the potassium is and potassium loss. So you're basically losing fluid, right? So if you're losing a lot of fluid, what could potentially happen? Hypotension. So this is very, very important and not good. And this is, again, Addison's disease, just as a reminder. So if you don't have enough of it and sodium and water are lost and hypotension continues, what do you think is going to happen? You're going to get your heartbeat is going to go really, really fast. So you're going to get tachycardia, which is another sign and symptom potentially, but that's a sign and symptom of a million things. But why do we get tachycardia? We get tachycardia because when we get hypotension, in case I'm sure you know this, but the reason why your heart starts to go faster is trying to compensate, right? It's trying to create homeostasis by pumping more blood around the body as fast as possible because you don't have enough of it. So it's trying to make up for that loss. So if this happens, unfortunately, we're going to have low cortisol levels. And this is going to, remember, we talked about how cortisol is there for us and it's a stress hormone. So what it does is it gives you kind of that boost of energy to be able to do what you need to do. And so what do you think is going to happen if you have too little of that? You're going to become hypoglycemic, which is going to cause what? You're going to be tired. You might have weight loss. Potentially, you could have confusion. And then this is another one that you could potentially have psychosis because it could become so bad. So these are all very, very, very important things to catch as early as possible so that we can provide treatment. I wanted to say that I think that's the bulk of the understanding. The other things are pretty blanket stated there. And I'm not trying to rush through this, but I do need to finish the quiz and get it posted. And a lot of this is if you watch the videos I put up already, plus the ones I added on, plus the one where I drew it out, a lot of this is, gonna make sense. So we already talked about complications of fluid loss. This is all on page 807. Diagnostic tests. Of course, you're talking about the kidney. So what are we going to do? We're going to test BUN. We just talked about cortisol. And we know cortisol has to do with blood sugar. So of course, we're going to go ahead and test the blood glucose. All sorts of things are going to be done. I just said it might be an autoimmune disease. So we're going to test different types of antibodies and, all of those types of things. So then moving along to Cushing's syndrome, where this will be our last one that we'll talk about, and then I will finish your test and get the rest of your study guide out. So Cushing's syndrome is basically like the opposite. So remember, Cushing, I think of, and I don't mean to be rude, I think of chubby, and that's where you get the, the hump on the back. It's called something else, and I'm going to see it in a minute in my notes. But anyhow, so I want to talk just a little bit about the patho of it. So basically, cortisol, aldosterone, and androgens are the 3 steroid hormones secreted by the adrenal cortex. We have talked about that over and over and over again. So cortisol is absolutely something you need to survive. You have to have it. We all have stress. We all have stuff going on. You must have this in order to be able to regulate your body and, again, keep homeostasis and keep everything kind of being able to have your body be able to handle stress, right? So when you have Cushing syndrome in general, the cortisol, when it's being hypersecreted, so now Cushing syndrome is hypersecretion. Hold on, I think I missed an important point that I didn't mark in my notes. I just want to make sure I get this in there. Did I talk about secretion? I'm going to restate it. So cortisol is essential for the survival of normal secretion, or secreted in rhythm, just in general, for your body to be working correctly. So if the secretion of the cortisol is increased during times of stress, which is true, right? We've already talked about that. And then we get more glucose. So then we're able to do what we need to do, and our body is helping us. So when you have Cushing syndromes, cortisol is hypersecreted without regards of stress. So you're not actually having the stress, but it's still being pushed out. And that's why you hear, like, on commercials, oh, you get belly fat when you have too much cortisol, that kind of thing. That doesn't mean you have Cushing syndromes. That's just kind of a relation of the two. So if this is happening, when the levels of cortisol are super high, the effects are usually related to excess aldosterone and androgens, which is a potential thing that can be seen. So I do want to do one certain thing for this particular one. So we'll talk about signs and symptoms, but beforehand, I want to talk a little bit about, just in general, the etiology, because, again, having the poster out, if you have it, it talks about how Cushing syndrome can be caused by hypersecretion of the ACTH. You'll see that on the poster, in the pituitary gland. And this is the most often result of a benign pituitary adenoma. And I'm actually reading this straight from the book because this is etiology. I don't memorize this. And that sometimes this ACTH is produced by a tumor in the lungs or other glands or other organs. And this is actually something, I've actually seen this in a patient. A patient had a tumor in the lung and it caused Cushing syndrome. And again, if you make all of these connections, you can actually put it together and say, wait a minute, you have these symptoms, signs and symptoms. This is what's happening. And they take a scan and they see something in the lungs and they draw the blood, and then they can put that connection together that, oh my God, this is what's happening. So signs and symptoms. So usually, as I had already said before, Cushing syndrome, people tend to get more cushy. So you're going to have weight gain. And as I mentioned earlier, with the excess cortisol, the central obesity. And we've seen that again on commercials, and we talk a lot about how cortisol can cause belly fat. So this is something else that happens. But oddly, the arms tend to be thin, as well as the legs. Why? No idea. Oh, the buffalo hump. That's what they call it. You get the buffalo hump, and then kind of a moon-shaped round face. And those are kind of the most noticeable, and that people start to notice. And then there has something to do with the skin. Let me, don't want to miss it because there is something important. Oh yeah, the hyperpigmentation. So because, so cortisol in general, that stress hormone, it does have some anti-inflammatory and immunosuppressive actions. So the patient is at risk for infection if they do have Cushing's. So hyperpigmentation of the skin can potentially occur. So this is another reason. And I've had patients come in when I used to work in a gynecological office and be like, oh, it's my birth control is giving me hyperpigmentation, this, that. And it actually ended up, not many, but I think maybe 2, but it actually ended up being that the patient had Cushing syndrome. So we have to rule things out. We have to look at things. And that's why it comes down to the diagnostic test. So if we potentially think the patient has it, of course, what are we going to do? We're going to always talk to the patient and take a history. We're going to take blood. in this situation, usually they take urine, and we're going to find out basically what is going on. Data collection is super, super, super important. I would like you to look at the picture on page 810, and then you can see kind of what the body of somebody with Cushing's syndrome looks like, with the thin extremities, the belly fat, the buffalo hump, the moon-shaped face, some hyperpigmentation, and different things going on. So that's basically what we missed. I didn't go, I mean, I went obviously into some detail, but I wanted to give some highlights. I think this chapter is written very, very well, especially the part that I didn't, or that I talked about is written very well, as well as when I drew out that picture. So I think now we are caught up as far as everything we were missing. And then on Monday, we will finish up with the, I keep wanting to say endocrine system. This is the endocrine system. We'll wrap up with chapter 40 and go from there. And I'm going to work on your test right now because I know it opens up tomorrow. I don't want to move it to, yeah, I'm not going to move it. I'm going to finish it tonight. So let me go ahead and stop this recording and post it for you. Thank you so much, you guys. And thank you for bearing with me through not feeling very well. I hope you got something from this. Thank you.